Good morning, everybody. This is Mrs. Franson, and we're going to be talking about Chapter 26. We're going to talk about crisis and disaster. Okay. A crisis can be individual or universal. It can be defined not only by the event itself, but also by the struggle to recover and adapt following the event. This slide gives you a formal definition of crisis for you to think about. So let's talk about it. Crisis is defined as a profound disruption of normal psychological homeostasis, which we'll talk about in a minute. It's a time when normal coping mechanisms fail. It results in the inability to function as usual, and it is usually an acute event and time limited. Profound disruption of normal psychological homeostasis actually means psychological decompensation. The ability to think, to perceive reality, to hold on to reality, is part of psychological decompensation. It can result in suicidal behavior, psychotic thinking, and violent homicidal behavior toward others. When we're dealing with patients in a crisis situation, what they want from us is help. They are in desperate need of support and help. What happens at the end of a crisis depends on three things. It depends on the patient's realistic perception of the event, adequate situational support, which is where we come in, and we call that crisis intervention, and adequate coping mechanisms within the individual. Now, we can directly control only one of these events. We can provide adequate situational support to our patients by providing them with emotional support and the opportunity to relieve themselves of intense feelings. We can't control the other two factors, but we can influence them by helping that person to see the situation realistically and to pull out their coping mechanisms that are inside of them. In the event of a crisis situation, the question is always this: will the person suffer personality disruption, or will they emerge with stronger coping skills? This is a form I filled out. I was hoping that we could do this in class, but I'm thinking we're not going to have enough time this week because of the ATI exam. So this is something I want you to think about. These are the factors determining the outcome of a crisis: perception, support, and coping. What can you do as a nurse to influence each of these factors? For example, can you correct a false impression that a person has? Can you offer emotional support? Can you encourage them to use the coping mechanisms that are already inside of them? How can you do this? What type of interventions can support these outcomes? We're going to talk briefly about crisis theory because I think it's important for you to understand where the modern thought comes from the way that we do crisis intervention. This began early in the 1900s because of a horrific event that occurred in Boston, Massachusetts. There was a popular nightclub there called the Coconut Grove. It was very popular, but the owners were not conscientious about safety. For example, the doors opened inward instead of outward. Many of the exits to the nightclub were blocked so that the patrons wouldn't leave without paying. And they didn't pay attention to maximum occupancy. They let as many people crowd into the nightclub as wanted to attend. One night when there were several hundred people there, a fire broke out, panic ensued. People tried to get out of exits that were blocked. They tried to get out of exits where the doors swung inward, and the end result was that 492 people burned to death in the nightclub. What has this got to do with crisis theory? There was a gentleman in Boston by the name of Eric Lindemann, and he was thinking about the event and decided to do a study, and he studied the survivors of the 492 people who died. And what he learned from his studies was that there were great similarities between grief and crisis, and that the things we do to help people through their grief, which we call bereavement, is the same thing that works for people that have been through a terrible crisis. So that was the beginning of modern day crisis theory. Now, Chaplin decided to study crisis intervention, and he's the person who developed many of the interventions and strategies that we still use today. Aguilera and Mesnick developed the framework for nurses, and Roberts developed a 7-stage model of crisis intervention, which we're going to look at next. This is an example of Roberts' pyramid, and it's also in your textbook. I put this on your PowerPoint because I want you to see that just like with Maslow, you start at the bottom and go up, and the foundation of crisis intervention, the very first thing that we do, we assess the needs of the patient and we determine their lethality level. What does that mean? That means, are they a danger to themselves, suicidal? Are they a danger to others, homicidal? We have to determine the safety issue before we can move forward. I also want to point out that the second thing we do is develop verbal rapport with the person and rapidly establish a relationship based on trust so that they will allow us to help them. Remember, when we have psychological deterioration, the result of that is profound confusion, depression, violence against others, and suicidal behavior are the potentials. There are different types of crises that may occur with our patients. One type of crisis is called maturational, and this goes hand in hand with Erikson's 8 stages of lifetime development. What Erikson found is that each of his stages represents a time when the physical, cognitive, instinctual, and sexual changes that are going on as we go through life prompt an internal conflict crisis. And the result of that crisis is that we're either going to have psychological growth or we're going to stagnate and have psychological regression. So if we resolve it in a positive way, we grow and we become stronger people. If we're caught up in it and cannot move forward, then we regress. Now let's talk about some examples of this so that you'll understand what I'm talking about. And I'd like to use adolescence as an example. When young children first move into adolescence, they're at a vulnerable stage. We're talking about kids that are 11, 12, 13 years old. Now, some of these kids become sexually active, but they don't have the judgment, the experience, the context of understanding the emotional ramifications of intimate relationships. So for young adolescents who become sexually active prematurely, this is a very negative experience for them, and it causes them a lot of psychological damage because they simply don't have the tools to deal with this level of intimacy at that age and time. Let's use another example. Let's use the end of adolescence. For most people that go through adolescence, their issue to resolve is to clarify their identity and to gain their independence. And so at the end of adolescence, they need to have an idea, a strong idea of themselves as an individual, separate from their family, able to go out and make a life of their own. Now, people do this by going to college, by getting their first job, getting their first apartment, that kind of stuff. So if you cannot successfully resolve the task of adolescence, then you feel frustrated, you have your anxiety raises, you have lower self-esteem, and all kinds of problems can develop. So that's just examples of two types of maturational crises that people go through. Maturational crises are internal crises, but you can also have external crises. An external crisis is a situational crisis. A situational crisis arrives from events that are extraordinary, they're external, and they're very often completely unanticipated. Let's take, for example, the loss of a parent in an unexpected way, like from a car accident. This can have a profound effect on children of all ages, including adult children. It is very hard for a person to lose a parent. And the more unexpected the event is, the more difficult it is for the children of that person to weather that crisis. When a loss or change threatens the person's self-concept, then their self-esteem goes down, their anxiety level goes up. And often successful resolution of any crisis depends on the resolution of grief associated with the loss that they're experiencing. Another type of crisis is an adventitious crisis. An adventitious crisis is unplanned and accidental. You are caught up in something of great force and magnitude. It may be a natural disaster, it may be a national disaster, or it may be a horrendous crime of violence. Now, this is a very traumatic event to live through. People often leave this type of crisis with an acute stress disorder like post-traumatic stress disorder or depression. For example, during World War II, at the resolution of World War II, many thousands of people throughout Europe were profoundly hopeless and depressed because of the losses, the trauma that they experienced during World War II, and the profound survivor guilt that they felt that they lived while so many of their loved ones died. What people need when they're going through a crisis of any type and of any level is they need psychological first aid. And another name for psychological first aid is crisis intervention. And nurses do tons of crisis intervention because they share life and death experiences with their patients. Let's talk now about the phases of a crisis. In the beginning, phase 1 of a crisis, a conflict or problem presents itself. Something about the event threatens this person's self-concept, which makes their anxiety go up. They're still able to think a little bit, so they try to use their problem-solving techniques and defense mechanisms that they use in their daily life. They try to resolve the conflict or problem because their goal is to reduce their anxiety. In phase 2 of crisis, their defense mechanisms fail, the threat persists, and their anxiety increases. They start to feel feelings of extreme discomfort, Their functioning begins to become disorganized. They may try to resolve their problem by some trial and error attempts because their goal is to restore normal balance and to lower their anxiety. In phase 3, their trial and error attempts fail. Anxiety is escalating now to a severe level or a panic level. They're not able to think clearly and use reason, so now they're going to have some automatic relief behaviors that are going to take over. And what are the automatic relief behaviors? Withdrawal. They may completely shut down and do nothing, or they may try to take flight. They may try to do some form of resolution, which would be to compromise their needs and to redefine the situation to try to find some way to survive it. Phase 4, their coping skills are completely ineffective. They are overwhelmed by their own anxiety and the situation. And this is during the time that personality disorganization begins. They may feel panic, depression, confusion. They can't think straight. They may become violent, or they may become suicidal. People will overeat. They'll drink. They'll use drugs, and I mean street drugs. They'll smoke. They'll withdraw, refuse to communicate. They may seek out someone to talk to. They may yell. They may fight. They may run around the room to release physical energy, run up and down the floor. They may do like religious worship, pray, read the Bible. They may threaten the healthcare providers. All kinds of responses are possible, and you will see them. So be prepared for that. Okay, now working with people in a crisis situation is very difficult for the healthcare provider. It's very exhausting. I can tell you it is very exhausting because you give so much of yourself in that circumstance. And there are some things that we have to ask ourselves so that we can do the best job possible. If you have a high level of anxiety, your patient will subconsciously feel that, and they will withdraw from you and not be able to share their true feelings. If you meet your needs at the expense of your patient, that will not be very effective, and I'm going to give you an example. It's very painful for you to accept the fact that your patient's going to die. So you offer false hope and false reassurance. And when you do that, you're helping yourself at the expense of your patient. So think about that and try not to do it. Also, it's very gratifying to be needed by your patient, so you may subconsciously foster dependence of your patient instead of helping them to be empowered. You have to think about that. You may set an unrealistic goal for your patient to meet your needs because you need to feel better. For example, if your patient is in total denial of a situation, you may try to force that patient out of denial instead of being patient and waiting for the person to move out of denial when they're able to do that. So think about that. You may have trouble letting go of the patient because it's a very intimate thing to share such an overwhelming event with a patient. But once that person leaves the hospital environment, that relationship should not continue. You also have to think about your biases, and you have to think about how you are going to handle it as a nurse when you fail. When you are not able to save that patient that codes, you're not able to save that child, you're not able to keep your patient from dying. Maybe you caused your patient to die by the mistakes that you made. Whatever the situation may be, how are you going to handle that and meet your needs so that you can keep on with your career and be effective as a nurse. Sorry about that. Okay. So you might consider using ineffective coping. They're not able to problem solve. They're often not able to meet their basic needs. They're not able to meet their role expectations, like for instance as a parent caring for a dependent child or as a breadwinner. They may not be able to communicate or interact in a social way, and they may use inappropriate defense mechanisms while they are in the crisis situation. So what we like to do is we like to focus on a single issue at one time, and we have to be reminded that in crisis intervention there are two goals, and the first one is always patient safety, and the second one is always anxiety reduction. So everything we do is focused to accomplish these two things. I want to remind each of you that crisis intervention is a basic level nursing intervention. You will be with people at some of the most difficult moments of their life, and this qualifies as crisis. And so your support of them will be very critical. These are just some thoughts about crisis intervention. Chapter 26 is full of some great ideas. We've already talked about the importance of providing safety. We also want to offer emotional support and hope. We want to offer emotional support. We want to be with the person, not leave them alone. And the hope that we offer them is that help is available, and we are not going to desert you during this time. We are here with you. So that's the hope we're offering them. It's important to state on a regular basis when you're interacting with someone in crisis, help is available. I'm here with you. I'm not going to leave you. You want to be genuine and honest. You want to maintain eye contact. Sometimes you can't get the person to listen to you until you get them to look at your face. It's hard for them to communicate, so help them by summarizing what they say and stating it back to them. What you're telling me is that you just watched your child get hit by a car and you are overwhelmed by this and don't know what to do. Help is available. I'm here with you, and I'm not going to leave you. You may need to make necessary short-term arrangements. Now let me say that all patients own their own lives, and we're trying to help them move to the point that they can make their own decisions, all of their own decisions. But sometimes they need just a little bit of short-term help. So what are some of the short-term arrangements you may need to make for people in crisis? Suppose you're with a wife in the hospital when her husband dies. One thing you might need to say is, who would you like to be here with you right now? And if she says her sister, her best friend, her children, then you can say, I'm going to contact those people for you. And you do that. You find out the numbers and you get those people there to be with her. You may be with a mother when her baby dies. And so you might need to say, do you go to church? Would you like your rabbi to come, or your priest, or your pastor? And if they don't have someone like that, you can say to anybody, and I mean anybody, we have a chaplain here at the hospital 24 hours a day. Would it help you if that person came? Sometimes they may want their baby baptized. We can make that happen. So you do what you can do to help that person. We can help people make funeral arrangements. We can call family members. for them and tell them what's happened and that we need for them to come to the hospital. So whatever short-term arrangements need to be made, it is generally going to be the nurse that does that. Once again, this is a crisis time for this person, so we want to focus on one issue at a time. And then sometimes we can help them identify personal strengths, and we can guide them toward the choices that they need to make. Now, with crisis intervention, we do primary interventions, secondary interventions, and tertiary interventions. For example, primary interventions are those interventions that try to prevent a crisis. And how do we prevent a crisis? We do that by promoting mental health and reducing mental illness. For example, we teach children to be assertive, to meet their own needs, and this helps them to have better mental health and less mental illness. Secondary care or interventions are those interventions that we provide for people that are experiencing the crisis. And then the tertiary interventions or care are those interventions we give to people who are recovering from a traumatic crisis event. For example, let's use the manager of a bank, and he's there in his bank, and a bank robbery occurs and several people die. And this is very traumatizing to him. He feels guilty, he feels responsible, and he is unable to return to his job as the bank manager. So you as a nurse, with the help of a case manager, a social worker, or case manager, can arrange for him to work in a sheltered environment that has much less stress so that he can get back into the workforce. Critical incident stress debriefing is a practice that we can use for those people who go through a crisis and for the responders to a crisis. For instance, there are some events that are so horrendous that it's damaging to the people who respond to help, along with the people who have experienced the event. And nurses fall into this category, and we're going to talk about that in a minute. I have posted a link on the next slide to an article about critical incident stress debriefing for you to look at if you'd like to learn more about this. I'd like to tell you that as a nurse, it is extremely helpful after a very difficult event has occurred in the healthcare setting for the staff to come together and offer support and a time of sharing, talking about the incident, and sharing your true feelings about how you have felt about this event that you've lived through. Even though you were not the person that it happened to, you were there and you were trying to help that person. And particularly when there's a bad outcome, it is very devastating to the people who are trying to help. I can tell you that I've worked med-surg, I worked OB, I worked peds. My personal experience was that OB personnel take their losses the hardest. And it's very hard for them when things don't go positively. Okay, here's that link I told you about, and I hope you'll look at this very excellent article. Know that nurses are at the forefront of disaster planning and response, whether you want to be or not. When there's a need in the community, nurses are called out by the American Red Cross, by the World Health Organization, by all kinds of organizations to step up and meet the needs of the community. Nurses are very much involved in planning for disaster response, and I encourage all of you to do your share of service to the community in the future in this way. I hope you've enjoyed this lecture and you've learned a lot from it. And this concludes the lecture. I'll see you on Monday.